David, I wish my mother could have been here to hear that. She wouldn't have believed it, but it would have been nice for her to be here. I want to thank you for the invitation. It is good to be here today, and I'm going to talk about something that I feel very strongly about, and hopefully there probably are some people in the room that believe in what I'm going to talk about. There's some other probably people that do not, and that's okay. I want to give you some disclosures. I do research for a couple of different organizations. I will not be talking about Sequenom or REVO. Both of those are actually out in the lobby, and you're more than welcome to talk to them. I have spoke for Hologic before, which I will be talking about some of their information. It's been about a year, but I'm going to follow the FDA guidelines. I don't even believe Hologic is here today, is what I've been told. So with that as my disclosures, this is probably the map that Dr. Adair was looking for, and I don't want to steal the March of Dimes talk here. It's always good to be first, because if you're first, then you can throw some slides in and kind of ruin everybody's talk, okay? So, you know, O'Brien, I got a couple in there for you, and I got a couple in there for you, Garrett, and yeah, exactly, so all you guys. You know, this is the most recent one, I believe, and you can look down there. There's always the red states, and it seems like I have stayed in the red states, and that's job security, I think. Unfortunately, Alabama's prematurity rate is almost 15%. I believe it's 14.8. That is down just a little bit. We can always look to our next door neighbor, Mississippi. They always have the worst by in pretty much everything. It is very sad, though, that those three states seem to continue to lead the nation. And I believe Tennessee was there several years ago, and y'all made some great strides in your ability to be able to prevent prematurity, or at least decrease your rate. So there are some objectives today. I want to talk a little bit about risk factors and mechanisms of preterm birth. We're going to move from there to talk about some diagnostic tools, and then go on to talk specifically about some management. And part of what I'm really going to push today is saving money. You know, I mentioned, and I showed that little slide there just a minute ago about prematurity going down, and it is. A lot of that prematurity going down, though, is this iatrogenic birth process that we have going on. Yes, if you look at fractionally, there are some very small decreases in other categories, but a lot of the progress that we made has really been between 34 and 37 weeks, which is a good thing. I'm 100% for that. But we still spend an enormous amount of money, and we're still nowhere near what we need to be in the United States. This graph does have a downward trend. We're nowhere close to where the March of Dimes or Healthy People initiative for 2020, and it's possible to meet the Healthy People's goal, which if you would have asked us a few years ago, that probably would have been impossible. As David was saying just a few minutes ago, the morbidity associated with preterm birth is staggering, and I'll probably talk about a case in just a minute or two that demonstrates that. But we know the morbidity and mortality is very, very significant, particularly in those infants delivered before 32 weeks of gestational age compared to term infants. The morbidity is also significant, and much of this morbidity continues throughout this child's life. There's economic and emotional cost to this whole process. Those of you who work in NICUs see this on a daily basis. You see these mothers or these parents that are essentially on a roller coaster. One day things are good, and the next day things are not so good, and it's just up and down. And some of these mothers have their children in there for months and months. So it is very much a emotional and economic drain, both on the cost of the care as well as the cost to the family of having to take care of the child and miss work. When you look at long-term consequences, the thing we all are concerned about is the neurodevelopment, and although it has gotten better over the years, it still is a problem, even a problem in the late preterm birth infants. when you compare them to the term infants. Pulmonary function has changed, cardiovascular has changed. You look at long-term for these children, their survivals are different as well as their reproductive lives are different. So there's just a lot of consequences. We all see slides like this talking about cost, and there is a tremendous amount of cost that we spend yearly. I think the last time I looked at my CV, it had 130 articles on it, and about 2/3 of them are related to preterm birth. And despite this, I'm not really sure that I really can say that I made a huge impact on this whole process. Yes, we've increased our knowledge, but the impact has not been there, to the point that when I walk in to see a patient, the first thing I tell them is, unfortunately, I can't prevent prematurity. I can prolong pregnancy and I can improve the outcome, but I cannot prevent prematurity. But those two things make a big difference in the outcome and in the cost. But there's a huge difference between a term baby and a preterm baby. And this last time this was looked at, $26 billion a year. So with that as kind of a little warm up, if you will, let's talk about preterm birth. And this is from the Institute of Health. They made this statement in a book called Preterm Birth. Preterm birth is not a disease for which we're likely to find one solution or cure. So right off the bat, it's telling us that we're not going to find that silver bullet out there. We're not going to find one thing. And we're going to hear about progesterone later today. We found a little something that we can diagnose, and now we have a treatment for, and it's starting to make an impact, and that's a great thing. But that's exactly what's going to happen, and you're going to see that as I talk through this. So there's not going to be a silver bullet. This is a very complex disorder. And because there are many etiologies, you're going to see, and we're seeing in our national meetings, many new technologies come out, new tests. You can diagnose infection, you can diagnose this, that, or the other. Ultimately, what's going to have to happen is we're going to have a test, a way to diagnose the problem, and then a treatment for the problem that's effective. And that's, without stealing John's thunder, what progesterone has found us in a very small segment of this whole syndrome. Roberto Romero gave me this slide a number of years ago. It's actually copyrighted. I don't usually copyright my slides. But yeah, Argentina guy. At any rate, and he's changed this a little bit over the years, but this goes to a number of the different protocols or the different etiologies for preterm birth, and they're listed up here for you. And we're going to talk about several of these, but the ideal, once again, of one thing being able to stop this process is just not going to happen. I don't believe that, and I don't believe any of these other people that are sitting up front believe that, because they're all so very, very different, and they initiate the labor process very differently. If we had to really look at it, though, we could break it down into four big categories, the causes of preterm birth. And these four categories do have some common mechanisms that come into play, and I'm going to spend just a minute here kind of talking about this. First of all, the maternal-fetal axis, this is related to stress, and so a fetus that's IUGR, for instance, is going to be secreting many different substances into their bloodstream because of that stress. That's going to get over into the mother, and we know that the fetus can initiate labor. So that is a major cause of preterm birth. Probably the biggest one, and the one that we get the most concerned about, is infection or inflammation. And the more indigent patients you deal with, the more likely this is to be the cause. And this has been a big, an area that has had an enormous amount of research over the years. The next is hemorrhage. We all know that blood, blood has prostaglandins in it. Prostaglandins cause contractions. We use prostaglandins to ripen cervixes. and to induce patients. It's no different if a woman bleeds prematurely, and particularly if that blood stays in her uterus. There's urotonics in that blood that ultimately will cause her to contract. And then the last one is pathological uterine distension, whether that's polyhydramnios, twins, triplets, quadruplets. Fortunately, those latter ones are becoming more and more unusual. I say that, and I currently am taking care of 5 sets of triplets. I don't know how that's happening when two embryos go in, but it seems to be happening more and more in my community. So there are some common pathways here. When you get on the outside, the stress-related category, those are related to enzymes or proteases seem to be upregulated, and that's probably causing the mechanism to take place. When you talk about overdistension, that's going to be uterotonics along with the hemorrhage, but the two in the middle really work on both pathways, and so really something that's going to be effective is probably going to have to affect both of those two pathways somehow to be effective. Ultimately, either one of these two are going to cause contractions, and we spent a number of hours yesterday talking about uterine contractions and some interesting technology that's coming out. But obviously there is those contractions, ultimately cervical change. Prom does occur. The more indigent patients you have, the more likely you are to have prom. And then ultimately this leads to preterm birth. Now that little middle thing that I didn't talk about, that fetal fibronectin, we're going to talk about because it's in the middle of there. And it is a common pathway, or it is something that we've known about for a prolonged period of time and can be beneficial to us. And in fact, when I was a fellow out in Southern California with Dr. Towers, one of your speakers here today, they were doing this study, and basically Tom said, everybody that has a risk for preterm delivery, we're going to do one of these tests on, we're going to do it every week. And we said, yes, sir, we'll do that. That's kind of the way it worked back then. But this was very interesting data. This was prior to FDA approval for this particular compound. And basically what we were able to show is in early pregnancy, fetal fibronectin being in the vagina is very common. But later in pregnancy, after about 22 weeks and up to about 36 weeks, in a pregnancy that goes to term, there's not supposed to be any fetal fibronectin present in the vagina. And so this obviously lends itself, if it is predictive, to be able to be utilized clinically. And that's ultimately what we're going to talk about a little bit. So what is fetal fibronectin? Well, fetal fibronectin is actually made by the pregnancy. It's a glycoprotein. It's superglue. And its job is to glue the chorion amnion to the decidua. And so that's what it is. And so obviously if it's being made by the pregnancy and its job is to glue those two surfaces together, then it should be up in the uterus. It shouldn't be in the vagina. And this presence in the vagina actually has some predictive value. So back when Adisa owned the copyright for, or owned the patent on fetal fibronectin, they went to the FDA and they got 2 different indications. And let me go over both of these with you briefly. First of all, it says up there it's the strongest predictor for birth before 32 weeks. I'm going to come back to that a little bit later, and I'll give you data to back that up. When the FDA first approved it, they approved it for symptomatic patients, which we're going to spend all the rest of this talk talking about, but they also approved it for asymptomatic patients. So let me give you an example of a patient that I used this on within the last 6 months. This young lady's a nurse. When she saw me, she was 33 years old. When she was 25 years old, she was being followed, worked in an ICU setting. She was followed for a routine pregnancy, and she felt a little crampy one day after a long 12-hour shift in the ICU. She called her doctor, told her doctor that she felt a little crampy. They told her to go home and rest. She went home and rested for a few hours, and it got worse. When she showed up to the hospital, she was 5 to 6 centimeters. at 25 weeks. They were able to tocolyze her and for about 36 hours keep the baby in utero, giving her antibiotics and corticosteroids, and she ultimately delivered a baby vaginally that stayed in the ICU for a prolonged period of time but did well. So pregnancy number one. Pregnancy number two is she gets pregnant again about 4 years later. She sees the same physician. He follows her, saw her about 21 weeks, was supposed to see her the day before these events happened. So 3 weeks later, she's 24 weeks now then. Same kind of thing, only it was much less, to talk to her, it was less severe. The contractions, or she felt a little crampy, but she rested, it quit. This time, by 9 o'clock, she had showed up to the hospital. She was 9 centimeters and went on to deliver without corticosteroids a 24-week child that did survive. That child had severe neurological insult, and actually her husband, because she was the primary provider for the family, ended up taking care of this child and was unable to work for about 3 to 4 years. And she swore she was never going to get pregnant. Well, it happened, and she shows up in my office, okay? I laid out a plan for her about how we were going to manage her during that pregnancy, and as part of that, I did serial fibronectins on her starting around 22 weeks of gestational age. And sure enough, at 24 weeks, she showed up with a positive fibronectin. No symptomatology. She had a cervical length of about 27 millimeters, as I recall. I put her in the hospital. I gave her corticosteroids. We watched her in the hospital for about 36 hours, and sure enough, boom, she went into preterm labor. We were able to successfully tocolyze her. Over the next 2 months or month and a half, I fought with her day in and day out to try to keep her pregnant. Ultimately, she delivered a 32-weeker, and that child did absolutely fabulous. So once again, I didn't prevent preterm birth. However, that fibronectin helped me predict that she was going to get into problems, and she ultimately did. You could have predicted that based on her history to a degree, but I probably would not. I could have potentially missed my opportunity. So that is one way that this can be used, and a number of clinicians will use this in multiple pregnancies because of their incidence of preterm birth. People with a history, people sometimes with short cervixes is another way that I sometimes decide how to manage those patients and whether or not to go ahead and give them corticosteroids, which I think Garrett's going to talk about a little bit later. So that's the first indication that they have, and that still is FDA approved for that. The other one is in the symptomatic patient. So this is the one that really gets us going because we spend a lot of time on these patients. They show up to our screening room, and the question becomes, are they really in labor or are they really not in labor? So let's talk about diagnosis. David, when I've got about 5 minutes left, if you could let me know. I think we started just a little bit late. I'd appreciate it. So Charlie Lockwood, who I found out is now down in Tampa as the dean, made this statement, and it was based on data, hard data. It's actually in up to date if you want to look this up, and actually in the practice bulletin. 80% of women that they get admitted with threatened preterm labor actually are sent home and go to term. Okay. Now remember, a lot of people that get admitted really are not even in labor. They're screened for a prolonged period of time and ultimately are discharged home. And so that brings us to question, do we really know what preterm labor is? And I have to really question whether or not I do. I don't know that I do. In fact, I'm pretty sure I don't, okay? If I ask any medical student or any resident in this audience what labor is, they'd tell me, well, it's contractions that lead to cervical dilatation. And that's true, but how many times do we see patients that have contractions that lead to cervical dilatation that ultimately stop and go home and then come back a long time later, okay? And so ACOG's definition of preterm labor is contractions that cause progressive cervical dilatation and effacement, or 2 centimeters and 70% effaced with active contractions. Now, other authors have defined this differently. Having said that, is that really what this is, or is this part of a normal process for a number of patients? A lot of people think that they have magic fingers and they can tell when somebody's in preterm labor. Well, obviously that can't be true, because I just told you that 80% of the people that we admit we actually send home, according to national data. So let me back up that data, okay, with a couple of studies. And I could have put 40 studies up here, but let me just talk about 2 as examples. Both of these are prospective trials. This first one, I believe David and I both were involved in. There's an antioxytocin out there called Intosiban. Intosiban is the #1 used drug for tocolysis in Europe. It did not get FDA approved. There were 2 studies. Sabai did one of them, and Romero was the big author on this particular one. It was a large, multi-center, prospective, randomized, double-blind, placebo-controlled trial. So the gold standard for diagnosing or seeing if something, an entity will affect an outcome, okay, had 500 patients in it, about 250 in each arm. Had a very strict definition of preterm labor. The definition was regular uterine contractions. I believe they had to have 9 or 10 that had documented cervical change and effacement by the same examiner. Now, that's pretty good definition of preterm labor. So one doctor examined them at the beginning and then re-examined them, and they may change, or they were over 2 centimeters and 70% with active contractions. Okay, so those were the 2 things. And look at the primary outcome. The placebo group, those patients that got saline, this was a real placebo-controlled trial. So half the people got intervention, half of them got placebo. The half that got placebo that had cervical change went on to term. Well, you know, Lewis, you're crazy. That's one of those big randomized trials, and you know, we don't trust that. So what else you got? Well, this is one center, published in the Gray Journal in 2007, comparing magnesium sulfate for nifedipine. We were still on this, trying to figure out which one worked the best. Single center randomized controlled trial, about 100 patients in each arm got randomized to either nifedipine or to mag sulfate. And you can see there, about half of the patients that got randomized, and by the way, same definition that we used on the other one, documented cervical change by the same examiner, okay? So half of these patients went to term, okay? So preterm labor probably is not what we think it is. It probably is something else, and something else is going to have to probably be used besides a digital exam to be able to determine that. Well, in patients that show up to my screening room, how do I decide if they're really in preterm birth or not? Because this is a common thing. This is something that we see. If you practice OBGYN or you're a nurse that deals with this, we constantly have these people show up and they're contracting. So the question that we all have is this real, or is this Memorex? Is this the real deal? Do I need to intervene, okay? And so we obviously have our clinical signs and symptoms. That's what we've all used. That's one of them we just talked about. We talked about cervical change. I'm going to talk about contractions in just a minute, and we're going to talk about the rest of these as we go through this talk, including fibronectin, again, and cervical links. So how good are contractions? Well, some of us in this room can still remember Tocos and Matria and some of the other organizations, and we used to have women strapped to beds all over the place, and we didn't really predict anything. We did run up healthcare costs, though. In fact, I still remember patients that I would put on, and I didn't overutilize the service, but there were some patients I did put on that I can remember patients that had a baseline uterine activity level of 11 contractions. That was her baseline, okay? And we all had patients like that. 11, that's every 4 or 5 minutes. I mean, it looked like she was in active labor, and this went on for weeks and weeks and weeks, and didn't do anything. So the bottom line is, this is from Jay Imes from the New England Journal. Uterine contractions are very poor predictors of preterm labor, and we all know that. We see this every day in our hospitals. Well, what about fetal fibronectin? This is still the study that's quoted, Alan Peaceman's trial. There were 7 centers involved in this. These are patients, 763 patients that showed up to screening rooms with symptoms of preterm labor. So they all showed up. They had symptomatology. and they did fetal fibronectins on them, and it was blinded, and they ran them in batch after the outcome. So this is a blinded observation. Now, anytime you try to tell if a test has good sensitivity and specificity, first of all, you have to have enough positive tests to be able to say that. And this one had 20% positive tests, primarily because most of these patients actually had documented cervical change. And what they were able to show in this trial, and this type of thing has been repeated over and over again, is that the negative predictive value of fetal fibronectin is 99.5%. Now remember, these are patients that show up to my screening room that have symptoms. Some of them actually had cervical change, and only 3 patients in this large cohort that had a negative fetal fibronectin ultimately went on to deliver prematurely within 7 days, and only 1 out of 100 delivered within 2 weeks. And so that's a pretty good test. And in fact, only 15% delivered prematurely, and these are people that are symptomatic, okay? So that was really the big thing that came out of fetal fibronectin, was not necessarily its positive predictive value, it's really its negative predictive value. Now I'm going to stop right here, and because the data's still out there, even though I've spoke for them before, I can say this, there is some new stuff coming out that nobody knows the answer to, but it's quantitative fibronectin, okay? And we're all very excited about this because this has a potential maybe of predicting real preterm labor, okay? The data's still out there. They haven't sought FDA approval. There's no way you can't get the test, okay? So that's only, so I'm just letting you know, you keep an eye out because it's pretty exciting if it falls the way it's predicted to fall. Why is all this important? I promise I'm not going to steal all your thunder, Garrett, okay? Steroids, transport, mag for neuroprotection, and tocolytic. Isn't that what you're talking about? Yeah. Steroids, David's already talked just a little bit about them. Let's take a look at this last study on this. This is the one that's most quoted. This came out about the same time that the NIH put out its consensus statement on steroid use. It's the Cochrane Review. Basically looked at 21 studies, about over 4,000 neonates, and what these conglomerates or meta-analysis essentially showed was a 30% reduction in neonatal death, 35% reduction in RDS, 50% reduction in IVH, 50% reduction in hemorrhage. NEC was over 50% reduction. NICU admissions decreased by 20%, and early systemic infections by 50%. So we're talking about something that has more impact than anything else, no question about it. I don't even know of another drug in medicine that has this kind of impact. I mean, this is this really changes lives is what it does. And so I always put a plug in for steroids anytime I have the opportunity. So why is that important? It's important because, you know, it used to be, back in the old days, we gave steroids kind of like candy, and patients would basically come in every week and we'd give them shots and all this kind of stuff, and now we figured out that that's not good. A little bit of something is good if it's done correctly. We know that by giving those steroids just before delivery, it's going to have its maximum impact. That's the reason why the college doesn't recommend outpatient steroids anymore. They recommend that you give them when there's an indication for them. They do allow now then, based on some very strong data out of the obstetrics network, giving a repeat dose if it's indicated and falls under certain parameters. I would imagine that'll be talked about a little bit later on today. But if they have a negative fibronectin, they don't need steroids, okay? Where's the data for that? Well, here it is right here, okay? So this is just an analysis looking at how many patients with fetal fibronectin testing you would have to do to prevent 1 case of RDS. Now remember, every baby doesn't develop RDS. If you've got negative fibronectin, you've got to treat 509 patients to prevent 1 case of RDS. If you don't even test, you've actually got a better chance, 1 out of 109, and if it's positive, you only have to treat 17 patients to prevent 1 case of RDS. And to kind of put that in terms that we all may be able to understand a little bit better, how many patients do you have to treat with severe preeclampsia to prevent eclampsia? It's about 100, okay? How many patients do you have to treat with neuroprotective mag to prevent cerebral palsy? It's about 70 to 80, somewhere in that range. And so 1 in 17, that's pretty good bang for your buck, okay? The real benefit to this from healthcare, we know those babies in the NICU cost lots of money. There's no question about that. And anything that I can do to prevent them from going to the ICU or save money or prevent spending money in labor and delivery is healthcare dollars I can use for something else. And so there's been about 20 of these studies out there. This is one from Houston. They basically implemented a fetal fibronectin to decrease healthcare costs, and they had a 40% reduction in their admission rate for preterm labor. In this one hospital, they saved $500,000 just off of this one intervention implementing is. And there's many other ways of looking at this. The other one is transfer. We're going to have a helicopter show up here. Those helicopters are not free. I know that it's very easy to make a phone call and say, hey, come get my patient, but there's a big bill attached to that helicopter, all right? And so if you had a negative fibronectin, why would you send that patient? So this is the reason why many big centers, and I know that Rich Perico has done this in Denver. He actually covers not only most of Colorado, which is a very rural state outside of a couple of centers, he covers all of Wyoming and part of Montana, and they actually have fixed airplanes that go out there. The DRG for preterm labor now is 2.1 days, right? I think it's 2.1, okay? So what they did was they put fibronectins out in all their periphery. They didn't send anybody in that didn't need to come in, okay? That saved a lot of money, so they went back to the insurers and said, hey, we're gonna save you, we saved you this amount of money. We want you to increase the number of days that these patients can stay because we don't think 2.1 days is enough, and it's not, quite honestly. And they were able to successfully negotiate that. And I think now then they can actually keep them up to 10 days in the hospital and get full funding, okay? I'll save it for you, Garrett. How about that? So there is some cost benefit to this whole thing. The last thing is tocolytics. Tocolytics, we obviously, if a patient needs them, if they're contracting, I do believe very strongly that I can prolong pregnancy for at least the 48 hours for corticosteroids. Many of these patients will stop. We will downregulate that uterus, and we'll be able to continue them on for longer. So short-term tocolysis is effective utilizing the right protocol. So protocols have become a new thing, and I'm not going to spend a lot of time talking about this, but we know protocols work. We know Group B strep, for instance. Many of us can remember when we didn't believe that we could prevent Group B strep, and now then it's become very, very uncommon by us implementing a protocol that actually Dr. Towers was very instrumental in back a number of years ago. What about a standardized protocol for preterm labor, utilizing some of these techniques that we've talked about? Well, we want to intervene on the patients that we need to intervene on. We don't want to intervene on the patients that we don't need to intervene on. There's a safety issue. All of these drugs that we use it's like any drug, there is a risk to that drug. So people that need to be hospitalized, that I need to spend healthcare dollars on, I want to spend it on. People that don't have it, I don't want to spend it on. And so in our institution, we've utilized fibronectin and saved a dramatic amount of money over the years. We also use some cervical links, and I will talk about cervical links, and I think that's another screening process that can be utilized in a triage area to save money. And these are just a couple of other examples. One group used it, decreased their hospitalization to 5.2 days before fibronectin to 0.6 days after fibronectin. So once again, if I'm looking at standardized protocols, I want to make sure the right patient, if a patient needs steroids, I'm giving them steroids. If they don't need steroids, why am I giving them those steroids? And I want to avoid that if at all possible. I want to reduce tocolysis. I want to reduce work for nurses. If it's indicated and they need it, everybody in this room wants it. If it's not indicated, why are they there? Why can't they be at home? Why can't I be drinking my coffee and people not bothering me, right? All right, let's do another case. So let's talk about how to do this. The 17-year-old at 26 weeks shows up. She's actively contracting. She has vaginal pressure. She has no bleeding or leaking. What's your plan of action? Well, obviously, the first thing I'm going to do is probably check vital signs on her, and her vital signs are good, and then I'm going to check vital signs on the baby. So she goes on the monitor, and the baby looks good, and so then the next thing I'm going to do whenever I figure out that she's contracting every 3 minutes is we're going to do a fibronectin. Now, it's real easy for me to say that. It's real easy for Dr. Adair to say that because he's got residents in this audience that are responsible for collecting those fibronectins, okay? I know some of y'all live in the hitherland where fibronectins are there's not a physician there, and you're having to take care of them. Well, actually, you can collect that just by separating the perineum and inserting the Q-tip in there. It is a Dacron. It is a specialized Q-tip. It's not just a regular Q-tip. And we'll talk more about that in just a minute. You can actually do it blindly, and it has exactly the same sensitivity as if you did a speculum exam, so for what that's worth. And in fact, at SMFM, I saw where the patients were collecting it themselves. I think that was an oral on the very first day this year. Obviously, the test is not useful if they've had intercourse within 24 hours, if you've done an exam on them, if they've had bleeding or anything like that. The other question that I get asked a whole lot, well, we don't want to do it because, you know, those little containers cost money. Well, actually, they don't. The company gives them to you free, and they don't cost anybody anything, okay? It will cost the company. So you want to obtain it before a digital exam, before a vaginal probe ultrasound, before you do any kind of test on them, because that can mess up your results. So many times we'll do the test and then we'll ultimately throw it away for some other reason. So you shouldn't do the test, or I don't utilize the test if they're over 3 centimeters usually, and I'll go through a little protocol here in just a minute. The test is easy. It's just a Q-tip in the posterior fornix. You leave it for about 10 seconds. I usually twist it. You want to get some secretions on there. That's ultimately where the fibronectin's at. And then you put it in the little container. You send it to the lab. The lab puts it in one of these little cute little machines here, and about 30 minutes later you get a result. It's either positive or negative, okay? So the good thing is it's not one of those things you got, you know, 8.2, is that positive or negative? No, it gives you a positive or negative. It's an ELISA test, and it's positive or negative, so it's pretty easy to do. This is the protocol we utilize at our institution. If they're greater than or equal to 3 centimeters, then we don't utilize the test at all. We go ahead and treat those patients if they're actively contracting. It's those that are fingertip, or they're 1 centimeter, or they're 50% effaced, or you know, those are the ones that we usually utilize it on, and if they're positive, it's going to lead to intervention if they're symptomatic. Remember that you got to do it prior to an exam. You don't want to miss the opportunity, because then you got to wait 24 hours. If they've had intercourse, they're bleeding, or they've ruptured, or there's any question thereof, then it's no good. All right, so with that as a little background here, let's talk about how to predict preterm birth. And I think I'm the only one that's going to get to talk about this today. So we're going to talk about risk factors. We're going to talk a little bit more about fibronectin. I want to get to vaginal probe ultrasound. David, how am I doing on time, buddy? 10 minutes. Cool. So these are the these are the risk factors for spontaneous preterm birth, and Bob Creasy thought that he could predict preterm birth by utilizing these a number of years ago, and he published a big article, and everybody was real excited, and then 3 other authors did the same study and found that it didn't predict anything, okay? And the problem is, if you look up there, about 2/3 of my patients, or 3/4 of my patients, have the vast majority of those up there. So history of preterm birth, we all know that's a big risk factor. We'll come back to that in just a minute. If you got twins or triplets or quadruplets, your risk goes up. Cervical insufficiency obviously increases your risk. Vaginal bleeding, African Americans are definitely at higher risk. Patients that are low pre-pregnancy weight, older or younger patients are at higher risk. Low socioeconomic status, maternal stress, smoking, which nobody smokes in Tennessee. That's the good thing. Nobody does drugs in Tennessee. So you don't have to worry about those two. And anemia, okay? Well, once again, most of my patients have all those, okay? So that's actually not true. This is data from Bob Goldenberg. When you actually look at these, how helpful they are, more than half the patients who deliver premature don't have any risk factors, and 2/3 of the patients with risk factors don't deliver preterm. So it really is not that helpful. Yes, history of preterm birth is important. Dr. O'Brien's going to tell you why in just a few minutes. I may throw a slide in there too in just a second. So when we look at risk factors, this is once again from Bob Goldenberg. This is a landmark article that he published in the American Journal of Public Health a number of years ago that has still stood the test of time. This is looking at preterm births less than 32 weeks. Now, I want to point out to you, you're going to see some data now, less than 32 weeks, less than 34 weeks, and less than 37 weeks. And these risks change dramatically whenever you look at it, looking at it from a different point of view. But basically, when he looked at relative risk of delivering preterm birth, contractions were not even statistically significant, okay, compared to patients who did not deliver preterm. African American race didn't matter. Pelvic infections didn't matter. Bacterial vaginosis did. The risk factor was about 2.5. Vaginal bleeding was about 2.5, and it also was statistically significant. Actually, low pre-pregnancy weight was not statistically different. History of preterm birth was. Makes sense. We all know that. I hope all the residents know that. The relative risk is about 7, so they're 7 times more likely to deliver before 32 weeks than those that have not had a preterm birth. If you have a short cervix, you're more likely to deliver prematurely. We know that. The relative risk is running right at 8. And I told you that fetal fibronectin predicted this better than anything else. The relative risk was a little over 14 relative risk for predicting preterm birth before 32 weeks. If one thing predicts preterm birth independently, if you have one thing that predicts preterm birth independently, you have another thing that predicts preterm birth independently, then usually whenever you combine those together, then it increases your ability to be able to predict that. Now, I want to point out to you, this is risk of preterm birth before 37 weeks in multi-parous patients only. But we all remember when we started trying to change risk for Down syndrome, we started with MSAFP and we found out if it was low, it predicted it, but it didn't predict it very well. But then we started adding in PAP-A and inhibin and all the other things, and the pickup rate increased dramatically. And actually, interestingly enough, the old triple screen, I still remember the whole process. I'm getting that old, but at any rate, the old triple screen used to pick up Down syndrome about 65%. Okay, that was the number. Okay, if you add cervical length, history of spontaneous preterm birth, and positive fetal fibronectin, predicting a preterm baby before 37 weeks, it's 60%. Okay, if you have a positive of all three of those things, so it's still not 100%. Vince Bergella gave me this a number of years ago. Actually, these two patients have exactly the same digital exam. So that's the problem with digital exams, okay? So the one going to be over on your left is a cervical length of about 4 centimeters. It's really long, and whenever you checked her, you're going to call her fingertip. The one over on your right, cervical length is about 1.8 centimeters in length, and it was called fingertip also. There's no question that these are radically different, okay? And they do predict preterm birth. When you have the one on the right, it directly correlates with the incidence of preterm birth. And this is a classic study from J. Imes. We all know this. The shorter the cervix, the more likely they are to deliver prematurely. It is a direct correlation, if you will. And this study has stood the test of time. Now we have therapy. John will talk to you about it in just a few minutes. Fibronectin will do exactly the same thing. This is data from the NICHD. Having a positive or negative fibronectin, these are Kaplan-Meier survival curves, if you will, the same kind of curves you look at whenever you're looking at cancer survivors, and you can see that they're very wide. All of these are highly statistically significant, showing that this does predict preterm birth at a very high p-value, less than 0.001. So, once again, if you add fibronectin into cervical length, and this is data, once again from the NICHD, even those patients with long cervixes over here, over on your right side, If you had a positive fibronectin, your risk of preterm birth was actually about the same as if you had a short cervix and a negative fibronectin. So the two together work very well in predicting preterm birth. I have an article in the Gray Journal from a few years ago that goes over this in great detail. Now, those of us that do sonography, we've all seen this. We've all seen the patient that comes in, and those of y'all that don't do that every day, this is just a cervix, and you can see it opened all the way down. If you examined this patient, you probably would say she's 1 to 2 because there is still some cervix just below this. But what I really have is B pointed to there. I want to pay attention to B, and that's a bunch of stuff that we see. We call it debris or sludge, we didn't know what this was for a very, very long time, and then a number of investigators have actually gone and done amnios on this stuff and figured out that it's a lot of cellular, a lot of white cells, a lot of macrophages. It's many times have bacteria in it, very high incidence of interleukin-6 and some of the other bad things. So this is not a very good finding. I don't usually present abstracts whenever I do professional talks. I'm still mad at George Soddy, and David, you can talk to him about why he hasn't, because I've already talked to him about it. I think that this study is not only intriguing, I think it's very, very important. George Soddy took the data that J. Imes did or had for determining that short cervixes predicted preterm birth in a linear fashion, and he went back and separated out those that had sludge on ultrasound and those that did not. And this was the first presentation 3 years ago at SMFM. And what he found was that a short cervix without sludge didn't predict preterm birth. It seemed to be the sludge, okay? And that's the point here. I talked to George about publishing this, and he tells me he's got too many other things right now, and then it's way down on his list. And so, vaginal progesterone, I'm going to save, okay? Yeah. All right, I'm almost done. I'm about there. So we have some interventions. I'm not going to talk about progesterone. I think cerclage is a talk in and of itself. Behavioral modification is the other one, and I still think we have to try. We've got patients that smoke. We've got patients that do illicit drugs. There are a number of other risk factors, and so we should never give up on our patients. We should continue to try that as mechanisms, but in my hands it doesn't work that well. But I can at least say I tried. I'm going to save your progesterone again. You're welcome. So I'm going to conclude now then and see if there are any questions. Preterm birth is still a leading cause of neonatal morbidity and mortality. It's a very heterogeneous disease process. Fetal fibronectin and vaginal probe ultrasound both seem to predict preterm birth. We know that. And fetal fibronectin can help you in those symptomatic and asymptomatic patients. And hopefully that now you can say that I've hopefully taught you something. I'll be happy to answer questions. Thank you so much for inviting me, David.